Hello, welcome to Unit 2 of the Certified Revenue Cycle Representative. My name is Robert Kiesacker. I am over the top excited to be able to talk to you guys about this module, this chapter, share some of my experience, and get to hang out with you guys over the next few minutes. I've had the opportunity to be in healthcare and revenue cycle for about 20 years. And this is actually one of my favorite topics to get to discuss. And I'm super excited to get to share it with you guys. So good morning, good evening, good afternoon, whatever time you are having the opportunity to listen to this. I hope you find this educational and helpful. All right. So Unit 2. We're going to talk about kind of the lay of the land that we're going to be discussing right now. So we're going to go over the first couple sections of Unit 2. We're going to talk about the type of patients, we're going to talk about scheduling, and we're going to talk about pre-registration. The types of patients. Types of patients that we see in the revenue cycle in healthcare vary. And it may seem like, it would be pretty self-explanatory, but there's a lot of nuances to this. Okay. So you've got scheduled patients and you've got unscheduled patients. You've got patients that are coming into an acute setting. You might have inpatients, you might have observation. But it's important that you kind of understand the differences in these patient types and what they mean for a healthcare organization. Okay. We also need to identify the different patient types and when to use each patient type. This can vary in reporting. This can change how we're going to staff, and it's important that you understand how this impacts either your facility or the facility that you're going to be working for. The types of patients. So we've got scheduled, unscheduled, and then we've got non-acute types. So a patient's first contact with an acute healthcare facility can either be scheduled or unscheduled, okay, depending on whether or not the immediate care is needed or if the service can be scheduled for a future date or time, okay? So if you have somebody that's scheduled, they've likely called ahead. We kind of have a general idea of what we're seeing. We understand the resources that we need. We might be able to collect some of that initial documentation, consent to treat. Maybe we can get some of that, past family social history. We can direct them to additional resources online, to complete any copays or co-insurances or anything like that. So scheduled patients are a very powerful thing when they're leveraged correctly. Unscheduled patients are just a natural occurrence within healthcare. You're going to have patients that are going to walk in. You may even have a designated walk-in clinic. And these, you're going to have to be able to be staffed appropriately to accommodate those unscheduled patients. And that may be getting them in, giving them a reasonable timeline, or even triaging them and asking them to come back later, depending on the services that they need, okay? And then you've got non-acute types. And we'll talk about those a little bit. Some of those non-acute are going to be skilled nursing facility, hospice care, home health care, and then maybe durable medical supplies. Maybe they need crutches or a wheelchair. Maybe they lost, a wire to a device and they're looking to just get some assistance with it. So within scheduled patients, we kind of break this down even more. We look at scheduled inpatients. These are individuals that, maybe is coming in for a long-term surgery. We know that they're going to be an inpatient for an extended period of time. Scheduled outpatients, again, we might see this in our ASCs or acute surgery centers. We might see this for mostly around, outpatient services. This also may be somebody that maybe is coming in for some sort of treatment. Maybe it's not a procedure, but we want to be able to continue to monitor them. And then scheduled reoccurring and serious patients. The thing that comes to mind with this are dialysis patients. Somebody that's going to be coming in and having something done over a longer period of time, that we're going to be able to schedule them, for several weeks, maybe even several months, related to their services. We try to, one of the things we try to focus on, one of the nuances with scheduling patients is we like to schedule services that we know are going to be high dollar or going to require significant, pre-processing or, resources, because we want to be able to account for that and make sure that um, that we've got the appropriate resources and we've got everything's in place to not just take care of the patient, but also to make sure that we're safe, and that we have a good outcome. Um, you imagine somebody coming in for radiation therapy or for surgery, there may be some prep that needs to happen ahead of time that we need to let the patients know. We want to make sure that we're prepared for that. Unscheduled patients. Okay. So, you know, I'll hop over to this second bullet: outpatients and walk-in patients, emergency patients. When we talk about the EDs, we talk about urgent cares. These are facilities that are specifically designed for an unscheduled patient. Um, EDs are one of the most common sources of unscheduled admissions. Patients arrive at the ED seeking care. If the patient meets the acuity criteria for admission, an order is written, and we admit the patient. Okay. When a patient is admitted, the admission will then be considered an emergency admission. Most health plans require notification of emergency admission within the specific time frame, usually about 24 hours or the next business day, just kind of depend. I know in our hospital, if a patient walks in at 1 in the morning on a Saturday, um, we may not be able to get that authorization until Monday morning. Okay, so it's greater than 24 hours, but um, we can get them on that next business day, and then that happens quite a bit. Uh, um, if you don't do this, if you don't contact them within 24 hours of the next business day, that may result in a denial of the claim. Just kind of depends on those payer rules. There are certain types, such as routine X-rays and laboratory tests, that are typically provided without benefit of prior scheduling. But as long as the medical necessity are there, and they're considered a walk-in, we can kind of a lot of times bypass some of that. Um, we talked about, inpatient and urgent patients as it relates to that emergency situation, outpatient and walk-in patients. So a lot of clinics have, an outpatient clinic, or allow, not outpatient clinic, but allow walk-in patients to come in, especially on Saturdays or off hours. And it allows for, to get those patients in to the clinic a little bit quicker. Emergency patients, really that ED is the best example. And then observation patients. Sometimes we have patients that, um, we want to keep an eye on, right? They're not, we're not sure that they're sick enough to admit them to make them inpatient, but there's some things, maybe we're waiting for some additional tests. Maybe there's some additional lab work, or imaging that we want to do, or maybe we just want to see whether or not the treatment that we're administering seems to be having the desired impact. So we might put them in observation. Okay. So it's just kind of a holding status until we can kind of see how they're doing. Okay. And then newborns. You can ask any parent. We do our very best. New parents, many of them they'll write their plans and then their hopes and their dreams of what they expect to happen. But anybody that's ever had a baby will tell you that you are on their schedule, and that includes when they come into the world. Okay? So we try to give a due date. We try to schedule newborns, and sometimes we can, especially with C-sections and stuff. But that baby's going to come when he or she is ready. So obviously that is an unscheduled patient, both for mom and baby. So all right. So non-acute types. So these are services that kind of have some specific nuances to them. So patients are admitted to skilled nursing units or facilities, CNFs, when they no longer meet the criteria for acute care. So they're not quite well enough to go home, and they just need a little extra care to kind of help them move along. Okay. Um, so they don't meet the acute care criteria, but they still need, what we might consider an inpatient level of care. So that's where the skilled nursing facility care or the rehabilitation services come in. This usually includes, orthopedic surgical patients who require intense physical therapy, or stroke patients. Anybody that needs either physical or occupational therapy might also fall into this criteria. Typically, Medicare will only cover services in a skilled nursing facility if the patient has transferred after at least 3 days of inpatient stay for a related illness or injury. During the pandemic, some of these restrictions were removed to the facility care. So, again, we are a couple years through the pandemic. We still have a couple of those criteria that are kind of floating around. So you want to make sure that you're checking your locality and what the rules are currently. Especially as this is being recorded, there may be changes that have happened. So make sure that you're understanding the rules in your area, depending on your facility type, what's going on at that time. Get into hospice care. Hospice care is kind of a change of mentality. We're moving toward more of a palliative model. Okay, we're not necessarily trying to treat a disease. We're not trying to cure a disease. We're trying to help this patient transition. We're trying to make them as comfortable as possible, and make sure that as they're going through, those last stages of life, that they are comfortable. Okay, and this creates some interesting challenges because somebody may be in hospice for a terminal illness like cancer or some sort of disease process, and then they have a traumatic injury. They break a bone or something happens, right? We still have to treat those traumatic injuries. In order to make them comfortable, we have to help them heal from that traumatic injury. They may not be directly receiving pain care for that terminal illness, but we still have to, there may be exceptions where we do need to move from a palliative to a, more of a traditional model. Hospice care is intended to provide humane and compassionate care for patients who are in the last stages of their incurable disease and have a life expectation of 6 months or less. Hospice services support the patient with pain relief and symptom management, but the disease is no longer treated. Okay, and that's the biggest thing is that we're not trying to treat the disease. Okay, if a hospice patient receives services under the Medicare program, is admitted in a hospital for hospice-related services, the hospice program is billed, not Medicare. Okay, so for many of us that maybe be treating a patient that is on hospice, we won't necessarily be, especially on Medicare patients, we won't bill Medicare. We'll actually bill the hospice because they have assumed the care for that patient. Um, then we get to home health services. Okay. And again, home health has always been around, and it's a pretty useful service out there. We saw some significant changes with home health, and kind of, really, I think it found its stride during pandemic. We did a lot more home health services. There was a lot more leeway underneath with some of the exceptions, but there was a lot of lessons learned with home health. Okay. So home health services can cover a wide range of healthcare services, which can be given in a home for illness or injuries, such as physical therapy, speech therapy, occupational therapy. Okay, as well as a whole gambit of other, um, you know, you see, even concierge medicine that's popping up, where people are coming in and doing exams and treatments, immunizations, blood draws in the home. Okay, so and then durable medical equipment, right? So medical equipment is deemed DME, and it is intended to be used over and over again. Examples includes wheelchairs, hospital beds, oxygen tanks, right? Again, especially during the pandemic, we were using a lot of oxygen tanks. Okay, um, and then finally, clinic. So a clinic is a facility or part of one that is devoted to diagnosis and treatment of outpatients. All right, moving on. So, key points. Um, the broad category of patients, depending on the type of care needed, are scheduled. Okay, so we really want to try to focus on having most of our patients scheduled, unscheduled, and non-acute types. So these are the three types that we kind of focus on. And again, depending on your clinic, depending on your scope, depending on your focus, it's going to change that mix up of scheduled, unscheduled, and non-acute types. Okay. Um, Patient scheduling ensures appropriate reimbursement and/or significant resource coordination, such as reserving rooms and/or equipment, ordering devices and supplies, and ensuring that professional staff, such as physicians, nurses, and estheticians, are available. Okay. Um, Although scheduling is kind of the preferred method, you know, you got to look at your facility. Each facility is going to have a different, kind of model. And, if you're an ED, you're not going to have many scheduled patients. That's just the nature of that service. So there are some nuances to this. So again, patients are considered schedules if a healthcare facility knows that the patient is coming ahead of time. Um, Many patients receive healthcare services that are not scheduled. Okay. These can be range from inpatient to outpatient to urgent walk-ins to even just outpatient walk-in clinics. Okay. And then non-acute services include the skilled nursing facility, hospice, home health services, clinical services, and DMEs or durable medical equipment. All right, a little bit of review. Which patients are considered schedule? Which patients are considered schedule? So is it reoccurring / service patients? Is it hospice patients? Or is it observation patients? Or last but not least, is it emergency department patients? I'll give you guys about 30 seconds to look at that. Think about how you would answer it. So when you approach a multiple choice, and this one's fairly simple, I'm a big advocate of, process elimination. Just statistically, you want to rule out the ones that are not correct. Okay. So which patients are considered schedule? Well, you're not going to see a situation where emergency patients are scheduled. It's just inherent part. It's an emergency. Okay. You don't typically schedule emergency. So we know 4 is out. Okay. So now we're at a 33% chance. Okay. Observation patients are typically not scheduled because they are an observation because they typically came in from the ED. Okay, so we're going to cross three out. Okay, so then the question then becomes: are hospice care scheduled, or is reoccurring in serious patients? Okay, now although a lot of hospice care is can be scheduled, we don't schedule to be on hospice. Okay, that is a different provider type, patient type. Okay, so the answer is one. Okay, patients who require services where the treatment is ongoing are registered as reoccurring or serious patients, and are categorized as scheduled. Services for scheduled patients are high dollar and require significant pre-processing to ensure appropriate reimbursement and/or significant resource combination. So if you answered number one, you are correct. Good job. All right, second one. How many days must a patient be inpatient for Medicare to pay a skilled nursing facility, the SNF? Okay. Is it number one? Is it number two? Is it number three? Or is it number four? Okay, so 2, 5, 3, or 10. And the answer is going to be three in all capacities. Okay, so it's number three, and it's also the answer is three. Okay, so three patients, or 3 days, I apologize. Um, but again, you want to be careful with this because you want to be, there were some changes that happened during the pandemic. Generally this is the answer, but you always want to verify that in your situation and in your area that this is the correct answer. Okay, but typically it's 3 days. All right, 2.2 scheduling. Okay, so some of the key points within scheduling. We're going to be looking at identifying the typical patient's demographic information, obtaining during scheduling. We're going to identify each component of the patient scheduling process. This section will include and address patient information, patient identification, requests of services, medical necessity screening, and our Medicare Advanced Beneficiary Notice. So key concepts. Scheduling patients for services allow the facility to prepare for the patient's service. Understanding and executing the process correctly is a key to patient satisfaction and to payment for services. Okay. There's a lot of science that goes into this. There's a lot of literature about this, but the patients can tell. Typically nobody wakes up and says, I really want to go and see a healthcare provider. They may because they're in pain or they're in discomfort, or maybe they just like people. But we're a service entity. And everybody that enters into a service entity wants to feel like they're being treated professionally, like they're being, like there was some thought that went into them coming in. If we were to compare this to a restaurant and you walk in and, the person greeting has a smile and they're well dressed and, they're professional, that starts off that visit, that business transaction in a positive note. You're like, oh, wow, this is a nice place. And then, you go to the table and you get, some water, maybe they bring you some chips or some bread. And they tell you what they're planning on doing. Hey, I'm gonna drop off some waters, and then I'll come back and I'll take your order. I'll find out what I can do. All of these things present a good presentation and make you feel good. The same thing for healthcare, right? You walk in the door, you should be greeted. They should be explaining to you what they need. They should be giving you a timeline. It should be an appropriate amount of time, and the steps should be followed, you know, very coordinated. Okay. So scheduling a patient for services allows the facility to prepare for the patient services by preserving time and obtaining information, equipment, resources required to provide that services. It also allows the facility the time to review the appropriateness of the service, screen for managed care requirements, and resolve any financial issues prior to the service. Okay. Completed daily schedules are used by service departments and the arrival area. If a patient does not go directly to the department to complete the final preparation of the patient's arrival, each component of the scheduling process will be discussed in some details in this study material. So, as these activities form the basics for pre-services registration and financial processing, okay? You need to understand, the key concepts. You need to understand, what's going on within scheduling and why it's important. So, some of our core concepts is patient identification. Um, I don't know if you guys noticed on my intro screen, I am the third, right? So my dad is the junior or the second, and then my grandfather, he was the first, right? So there's times where, my dad and I have gone to the same medical facility. We've got the same provider. So I may come in and they say, "Hey, I'm here. I have an appointment for Robert Keysacker." Well, it's really important that they look at date of birth. They look at address, right? They're looking at occupation. These are things that they should be insurance. Um, my dad was in the army, so he's got that TRICARE for life. I work for a hospital, so I've got that their self-funded program, right? So these are important things to kind of be aware of is identifying that patient, making sure that there's no changes, and that it's appropriate. Okay. Um, you want to verify requested services. You want to make sure that you have what you're expecting them to come and have done is the same thing that the patient is expecting to have done. Okay. Because if those don't align, then that's kind of a check and balance. That's something that's an opportunity to catch before you've either rendered services to the wrong area, to the wrong part, or you've mixed, something got mixed up in translation. So it's very important that you understand that you and the patient and the facility are all in agreement of the services that are going to be provided. Okay. Hey, you're here for a well visit. Hey, you're here for a colonoscopy. Hey, you're here for dental services. Okay. Um, we have all three of those, and you may be talking to a check-in person that has the ability to schedule all those. And we don't want to send somebody to get a colonoscopy when they're here for a tooth cleaning. So it sounds funny, but it is something we want to verify, right? Scheduling instructions. We talk about that colonoscopy. Hey, did you do your pre-work, right? You haven't eaten anything in so many hours? Um, did you complete, whatever regimen you needed to do prior? That may affect our ability to do that service. If you can catch that at registration, then you're not getting the patient back and prepping them only to find out that they can't do what they were there for. Okay. So you want to verify your scheduling instructions. You're going to review and validate. You're going to make sure that everything seems to be copacetic or in line with what you're expecting. You may be giving them patient reminders and arrival instructions. You're going to be explaining to them, hey, this is where your services are going to be. This is the date. This is the time. This is how you get there. This is the floor that we're on. This is where you might park. This is where people are going to pick you up at the end. All of these, patient reminders and arrival instructions. You may even put it on a piece of paper or send it digitally. And then you're going to make sure that you have all of the order requirements kind of met. Scheduling process. So patient identification. So when there is a request for a service, scheduling staff must confirm the patient's key identification information to ensure they have access to the patient's account. So the first important step in scheduling, identifying the patient, healthcare information systems maintain historical database for every patient who had services within the healthcare system. So critical patient information includes patient's full name, their date of birth, their gender, possibly social security number. Each patient is assigned a unique number, commonly called a master patient index number, um, or a patient identification number. Uh, Individual episodes of cares are linked to these numbers, and enable the provider to identify all services provided to the individual patient within the healthcare setting. When there is a request for services, the scheduling staff member must confirm the patient's unique identification record to ensure that he or she is accessing the correct information or the historical data. We want to make sure that everything's going into the right chart, right? Obtaining and confirming the accurate patient information is extremely important in order to avoid data errors such as duplicate medical record numbers or choosing the wrong patient. Okay. Once the correct patient is identified, remaining demographic information is obtained, validated, or updated as necessary. Hey, I got a new phone. Hey, I moved. Stuff like that, right? Getting those addresses updated, getting those phone numbers updated. Emergency contacts, maybe, you got married or you're dating somebody or whatever, that some of that information may change. The following is listed the typical demographic information. So obviously the full name, you want to have patient's date of birth, you want to have social security number if you're collecting that, the patient's sex, their marital status. You want to understand you want to have their address. You may have your phone number. There may be multiple phone numbers. You want to know their race. Do we know their occupation or employer? And then name, address, and telephone of any emergency contacts. Okay. Now, some of these may seem like, well, why are we collecting that? Well, employer is kind of interesting because I can look at an employer and that gives me a couple indications of things. So, from a clinical perspective, there is certain occupations that have occupational hazards. There's dangers that maybe we want to review. Maybe there are mechanisms of injuries that we want to take into consideration. From a revenue cycle standpoint, if I know that somebody works for a certain company, I may know who their insurance is. Okay, so I may say, "Oh, well, who's your employer?" And they say, I don't know, we'll pick one, Walmart, right? Maybe they work for Walmart, and I know that Walmart has, whatever health plan. Okay, but then they gave me on file, I have a different health plan. That may prompt a question of, hey, do you still have this insurance? Or, hey, I see you work here. And that may open up a conversation of, oh, no, I'm covered by my mom, or I'm covered by my dad, or I'm covered by my wife or husband. There's different dialogues that have there that information can kind of help prompt. Requested services. So physician's order is generated and become the basis of request for services. So physician order is generated and become the basis of the requested services. The contact for the requested services can come from the patient's physician's office or a service department in the healthcare facility. If a patient is scheduling the service, he or she is given a written physical order from the physician's office. It could be faxed, it could be written, or it could be electronic, and it is asked to call and schedule services when it is convenient for the patient. Okay, so let's say that you go and you have an injury. Okay, I had one, a few months ago. I was having some abdominal pain, and I went to my provider, and he's like, you really need to have a chest X-ray. I want to find out if maybe you have a small fracture in one of your ribs. Okay. So he wrote an order. He gave me the order. I went down to an imaging facility down the road and said, "Hey, I need to get a chest X-ray. I need to get an X-ray of my ribs to see if there's a fracture." Okay, and then they were able to do those X-rays, and then they sent them back to the provider. Okay, patient usually schedules services such as ultrasounds, mammograms, stress tests, or therapies if the physician office to typically schedule surgery cases, catheterizations, or more invasive type procedures. Okay. So if it's something that the patient can schedule, maybe it's lab work, maybe it's imaging, they'll typically allow the patient to schedule. But if there are additional resources, say we need to schedule time within an OR or an ASC or something along those lines, that'll typically be handled by the doctor's office because they may need to be coordinating with that facility as to when their resources are available. It's a little bit harder for the patient to do. So it can be done by either the patient or the provider, depending on what the services are that are needed. Scheduler instructions. So the type of requested services will determine the scheduling instructions. Many healthcare organizations, such as use automated scheduling systems and build the scheduling questions in the system. So the type of requested services will determine the scheduling instructions. Instructions to the schedulers range from the basics such as amount of time needed for the test to complete, when room, equipment, and personnel must be coordinated to provide the needed services. Many healthcare organizations use automated scheduling systems and build the scheduling questions in the system. So the scheduling system prompts the scheduler to complete required scheduling instructions each time a test or procedure is requested. Gives you a little bit more continuity, and everybody's kind of getting the same questions, establishes a baseline of what to expect. If an automated scheduling system is not used, a binder including all scheduling instructions should be maintained to facilitate the scheduling process and ensure all critical information are completed. One example of scheduling instructions would be for a nuclear medicine procedure. Contact the department to order isotopes. Make sure that we have what we need to complete the services. Reserve the procedure room for however many minutes we're typically going to expect to take. Okay, maybe it's 60 minutes, maybe it's 90 minutes, maybe it's 30 minutes. Inform the department if a patient is in a wheelchair. Okay, that may require additional people to help them transition. Maybe maybe it's going to require a different modality. One of the things that comes to mind is when we're doing MRI procedures. We want to be cautious about metal. So you want to understand what physical limitations that patient may have, so you account for it. Provide medication instructions based on the type of test order. Okay, so maybe you need them to take a different medication, maybe you need them not to take their medication. Those things all come into play depending on the services being provided. All right. So scheduling process, the patient's instructions. So the scheduled procedures routinely include patient's preparation instructions that must be completed prior to the test procedure. So the scheduled procedure routinely includes the preparation instructions must be completed before the test or procedure is being done. By providing accurate instructions during the scheduling process, the schedule ensures that the patient will be properly prepared for the services they're going to receive. Examples of commonly used patient instructions include refrain from eating or drinking anything after midnight. Take all prescription medications take all prescription medication on the day of the test. Okay. So sometimes, we may ask the patient not to take the medication. Sometimes we will ask them to take the medication. It just kind of depends on kind of where we're at with that. Okay. Um, um, why is it doing that? Yeah. All right. So, and then the last one is at least 90 minutes prior to the examination, drink 24 ounces of water. Okay, so maybe we need to fill that bladder, or maybe there's something else that needs to happen. So, these instructions to the patients are kind of letting them know what they need to do in order to, kind of have that test be as efficient and as effective as possible. Okay. Before finalizing the scheduling contact, all components of the scheduling contact are reviewed and validated. So make sure that everybody patient understands what the expectations This important step is used to verify that the patient is complete and accurate information. The following information should be reviewed as part of the scheduling finalization. Okay, so these are some of the things that should be reviewed. The service to be provided. So what services are they receiving? The date and location of the scheduled services. Okay, so when is this going to happen? Make sure that they understand what time they need to be there. If the surgery or procedure starts at say 9 o'clock, maybe you need them at the facility by 7:30 or 8 o'clock, right? Verify the patient is clear on the scheduled test time and required arrival time. Required pre-services testing include completion time frame. Okay, so you need to make sure that they understand really what they need to do prior to having the services. Make sure the patient understands any pre-preparation instructions. Patient arrival instructions such as where to park, where to report to, and how to get to the service area. Okay, so just validating that with the patient will save you a lot of challenges, and make sure that you're on schedule and you're able to do these services when you intend to. So, patient reminders and arrival instructions. Excuse me. So the patient's reminder is a written listing of the patient's responsibilities and usually includes the same items summarized at the end of the scheduling call, along with any additional instructions provided as part of the additional access processing activity. All right. So the patient's reminder is a written listing of the patient's responsibilities and usually include the same items summarized at the end of the scheduling call, along with any additional instructions provided as part of the additional access processing activities. Required insurance forms, expected time of service payments. Reminder letters can also include maps that show the patients where to park, where to report, when he or she arrives, and where the service department is located. These notices may be used to reduce the incidence of no-shows or non-compliance with the test instructions. Many facilities call the patient a day or two prior to the scheduled visit to remind him or her of the appointment. Okay. So we want to do everything we can to try to assist and make sure that that patient is where they're supposed to be when they're supposed to be there. For the patient's convenience, for our convenience, we don't want to spend money, especially with some of these isotopes, and have everything ready only to have to cancel the service because something wasn't done or the patient's not there. All right. To review and validate information to review. The service to be provided, the date and location of the scheduled service, the arrival time and procedure time, the required pre-services testing, including completion time frame, the patient's preparation instructions, and then finally the patient's arrival instructions such as where to park, where to report to, and how to get to that service area, and when to be there. Okay. Patient reminders and arrival instructions. Reminder letters can also include maps that show the patients where to park, where to report, and when he or she arrives, and where the service department is located. Many facilities call the patient a day or two prior to scheduling visit to remind them of the appointment. All right. Order requirements. Tests and services can only be provided with a valid physician order. So these can be verbal orders, um, or it can be a written order. Okay. Medicare has certain date requirements to consider a physician order. Okay. So you need to know the full name. You need to know the tests or services that's being ordered. You need to know the name of the ordering provider, the date the order was written, the diagnosis to show medical necessity, and then it has to be signed by the provider. Okay. Tests and services can only be provided with a valid physical order. The few exceptions are requests from Medicare beneficiary for flu vaccines, pneumonia vaccines, and screening mammographies. You don't need an order for those. You can just go in and have them done. Initially, verbal orders can be taken as long as they are accepted by qualified staff as defined in the facility medical staff bylaws, rules, and regulations. All verbal orders must ultimately be authenticated by the ordering physician by a subsequent written signed order. Okay? Medicare requires the following data elements to consider a physical physician order valid. Gotta know the patient's name, gotta know the date the order was written, the tests or services ordered, diagnosis, coded diagnosis or narrative description of the reason for the test arrival, name the ordering physician or allied healthcare professional, signature of the physician or AHP. Basically, you need a signed order. It has to be signed. Orders must be written on a prescription pad, documented or pre-printed form, or electronically generated and transmitted by the physician's practice computer system. These orders must include the physician's address and telephone number, their NPI number, the patient's date of birth, patient's sex, the patient's social security number, and the patient demographic and health plan information. ABNs, medical necessity screening and ABN processing. Medicare will only pay for tests and services that determines are reasonable and necessary. Okay. However, there are some services that are deemed not medically necessary. Okay. So if a test or service is not medically necessary, as defined by Medicare, a signed advance beneficiary notice or an ABN must be obtained from the patient. Okay. This is a transfer. This form transfers the liability, the payment liability, to the patient. Okay. The Medicare will only pay for tests and services that is determined as reasonable and necessary. Medicare has established guidelines called local coverage determinations, or LCDs, and national coverage determinations called NCDs. These establish which diagnoses, signs, or symptoms are payable per the policy. If a test is ordered where an LCD or NCD exists, there must be documentation of medical necessity in order for the Medicare to pay for the test or service. If a test or service is not medically necessary, according to the LCD or NCD, a signed advance beneficiary notice or ABN must be obtained from the patient. ABN is not used for inpatient services or for tests that are always excluded from Medicare payments, such as acupuncture, experimental tests, or research testing. Medicare provides other forms in these situations. The purpose of an ABN is to give the patients advance notice that Medicare may not pay for the tests or services ordered and the associated costs, which will be billed to the patient. The ABN must be issued to the patient before providing services related to the ABN. Generic, routine, or blanket ABNs are not acceptable except in cases such as frequency limitations where all patients are at risk. Good integration. What did I just do? Color. Okay. Hospital issued notice of non-coverage. Okay. So medically unnecessary, not delivered in the most appropriate care settings, and custodial in nature. Okay. An ABN is not used for inpatient services. The inpatient counterpart to the ABN is the HINN and should be provided to beneficiaries prior to admission at admission. or at any time during the inpatient stay if the hospital determines that the care the beneficiary is receiving or is about to receive is not covered. A good example is a mom or grandma was in the hospital and her family was notified on Friday that the physician put in orders for her to be discharged. When the family was contacted, they informed us that they were going away for the weekend and no one would be available to pick up the mom until Tuesday. Um, this is an example of the remaining stay being custodial in nature. So they may be given this form basically to state that they are going to be responsible for the additional days that that mom is going to be in the hospital. Key points. So key patient information includes the patient's full legal name, date of birth, social security numbers are collected and used as patient identifiers. Medicare has established guidelines called local coverage determinations or national coverage determinations that are used to determine which diagnosis, signs, or symptoms are payable. Tests and services can only be provided with a valid physician order. Okay? Make sure that within these, the key patient information is included. Patient's full name, date of birth, sex, social security numbers are all collected and used as patient identifiers throughout this. Uh, okay, so now we're going to kind of test some knowledge. To name the guidelines that Medicare established to determine which diagnosis, signs, or symptoms are payable. So is it A, an advanced beneficiary notice? Is it 2, a local coverage determination? Is it 3, patient identifiers? Or is it 4, scheduling instruction? Okay. To name the guideline that Medicare established to determine which diagnoses, signs, or symptoms are payable. Okay. So probably not going to be 1 because that's an ABN, that's advanced beneficiary notice. So that's kind of determining, hey, this may not be payable because it could be considered not medically necessary or experimental. Number 3 and number 4 are components of the visit, patient identifiers and scheduling instructions. But an LCD, a local coverage determination, is a guideline from Medicare that establishes and determines which diagnosis, signs, and symptoms are payable. Okay? So number 2. The other answer that's not on here is you can have either an LCD or an NCD. So one is determined by your locale, typically by your MAC, your Medicare Administrative Contractor, and the other one is more, national CMS. Okay, so either an LCD or an NCD both determine which diagnosis, signs, and symptoms are payable for particular treatment. All right, to 2.3, pre-registration. So in this section, we will discuss the pre-registration purpose and process, information collected during pre-registration, consequences that an organization may experience due to inaccurate or incomplete patient information, and an overview of the Medicare secondary payer screening process. So we're going to identify the data that must be obtained and confirmed during pre-registration. We're going to identify the purpose and importance of insurance verification and the Medicare secondary payer MSP screening process. And we're going to identify the consequences of failing to obtain and confirm patient information during pre-registration. Okay. A reason for pre-registration. Okay. The successful pre-registration program should gather the following information. Okay. And if you haven't done so, go hug a patient registration person or patient access person because their role is so incredibly important in our revenue cycle. They are kind of the unsung heroes of this team because if they don't get what they need to get done, it causes kind of it causes a string of events that really make things very challenging. Okay, so it's very important. Um, so demographic information, making sure that we have the patient's name, their date of birth, um, their address, their phone number, all of that information. Make sure that we have the right patient and it's up to date. Their insurance data. Um, they are seeing the patients. They are working with the patients. So making sure they have a card, making sure that we scan that card, making sure that the card is valid, verifying that information. Okay. Any financial information. Um, do, have they changed jobs? Have they changed? Sometimes knowing the income can affect. Might be collected in pre-registration. Um, Insurance information. Do we know? Do we have a card? Do we know where we're going to be billing? Is there a copay? Is there a deductible? Is there a need for financial assistance? We can have that conversation right then and there to kind of help them be successful and make sure that we can get them the treatment they need without putting them in some sort of financial hardship. Give the patients preparation instructions. Let them know what the expectations are, what they need to do, what their piece of this service is, and then collect the patient's liability. If there is a coinsurance, if there is a deductible, if there is any patient responsibility, this is where it should be happening, or it's an opportunity for where it could happen. All right. Benefits of pre-registration. So the patient arrival process is completed efficiently. Paperwork, both clinical and financial, can be assembled ahead of time. Patients can expedite the registration process. Patient can report directly to the service unit, and patient can focus on clinical care and treatment. Okay? So there was some time studies done a couple years ago, and they took a patient and they had the wait time be like 45 minutes to an hour. Okay. And what they found was if somebody sits 10 minutes in the waiting room and 35 minutes in the exam room, that was more desirable. They had better patient outcomes, better patient experience than if they spent, um, 30 minutes in the lobby and 10 or 15 minutes in the exam room. But getting them from patient registration to the exam room, even if they were in the exam room longer, that had a better patient experience than if they were in the waiting room. So getting them through that registration process gets you better patient experience. Okay. Patient's going to have a better outcome. They're going to have a better experience. Um, they want to get into their exam room. They want to get to that point, get to, the care that they're expecting to receive. Okay. So the process of pre-registration ensures the patient's access staff has been completed and valid information needed to finalize any remaining pre-access activities, including Medicare secondary payer screening, medical necessity screening, insurance verification, pre-certifications authorization, any managed care requirements resolution, financial education resolution. Um, it's very important that you get all of this stuff taken care of, and you understand and you resolve any of the financial issues or concerns. So that way that patient can focus on whatever testing or treatment or medical side that needs to happen. If you can get that patient resolved administratively, then they can focus on what they need to do. They can focus on the reason that they're there, which is to, see that provider and get the treatment or the exam that they need to have done. Data collection. Okay. Um, it takes a village, man. There's a lot of us that we need to work together in order to be able to get this. The purpose of initial pre-registration step is to identify the patient that has been and has been a previous patient, has an existing medical record number. Okay, each patient with a historical record in the facility's registration system is assigned an NPI number or some sort of chart number, and you need to be able to search it, and you need to be able to validate all of the information that's in there. All right, NPIs and data collection. Okay, so it's really important that we're validating the patient's identification. We're making sure that all of this stuff is in place. Okay, so comprehensive access processing, identify the patient's medical record number or NPI, creating a registration record, completing any medical necessity screening, determining insurance eligibility, and obtaining insurance benefits, resolving managed care requirements, and completing financial education and resolution. Okay. First critical step of all patients arriving for service, scheduled or unscheduled, is verifying the patient's identification. Okay, making sure we have the right patient. Express check-in should be established for scheduled and pre-registered patients, either in a designated area or within a service department. Because pre-service system processing has been completed, we can kind of expedite that process. Okay. For a patient with no, medical record number, that's going to take a little bit of time. So we need to generate it, and then we need to make sure that we have their full legal name. Okay. A lot of times there is a place for nicknames or what they want to be called, but we want to make sure that we've established their legal name. The minimum requirement, we should know their gender, we should know their date of birth, their address, their phone number, additional information, obviously race, ethnicity, social security number if possible. So consequences for improper data collection. So wrong medical history, billing information is not correct, and incorrect medical record number. These cannot be overstated. Once this error occurs, it becomes harder and harder to fix, and it requires more resources that are involved. This may include, self-disclosure. You may have to contact the patient and say, hey, we sent the wrong information, or we did the wrong thing. You may see delays in payment or reimbursement because we didn't have the right information. So there's a lot of consequences for not collecting the right data as it moves through the revenue cycle and that medical visit. Okay. So serious consequences may occur if patients are identified incorrectly via generation of a duplicate medical record number or by selection of the wrong patient's record. Treating a patient with the wrong medical history, patient can have serious adverse reactions to a treatment since their allergies, medical conditions are not correctly identified. Okay? If insurance information is wrong, then the patient's claim is sent to the wrong health plan. Explanation of benefit statements are sent to the wrong patients, thus resulting in serious breach of confidentiality and could be considered erroneous billing. Okay, so we really need to make sure that this is correct because it can have some really bad effects, both financially, clinically, or from a risk standpoint, from a compliance standpoint, and then finally, clinically, we may be putting the patient at risk. So we got to be very careful about this. Insurance verification. So insurance verification is considered. Insurance verification is conducted to ensure the accuracy of insurance information. Covered issues are identified and communicated to the patient. can be completed through electronic inquiries or telephone contacts. The Medicare secondary payer screening. Okay. So the MSP screening questions help to clarify the patient's situations, including their working age, their disability. Do they have end-stage renal disease, any accident or auto worker compensations? Okay. These are literally the criteria that we have to establish on an MSP. Okay. For Medicare patients, an important component of pre-registration process is effective completion of the Medicare Secondary Payer (MSP) screening process. This basic MSP rule are discussed in 1.6. Okay. So Medicare and compliance regulations for patient access step, understanding both the MSP rules and how to use the MSP. Questions are essential. Many facilities have developed computerized MSP forms that guide staff through the required questions. This is another topic that is repeated in a few sections. So understanding the MSP rules is important. Anyone who has worked in the patient access will tell you that patients don't really understand this. They'll tell you that the MSP can be very, very confusing. So you have to kind of go through this with the patient. You need to kind of help them understand what the expectations are, just so they understand how it's going to work and how you're going to be billing insurances and how it's going to have to be affecting the patient. Incomplete pre-registration. So return mail affecting the ability to contact the patient or collect self-pay amounts. Insurance denials in an unnecessary health plan follow-up and rebilling resulting in higher rework costs. The cost of denied claims. Okay. So the average cost to rebuild a claim, if you can, is $50 per claim. When the claim is reworked, analyzed, denied, requesting additional information, reviewing notes and documentation, appealing the denial, and repairing and resending the claim, the amount earned is dramatically reduced. So, if you're looking at a claim that your compensation, you're looking at the allowable amount is $100 and you have to resend it, you're only getting 50, you're getting paid the full amount, but your operational cost is an additional $50. So it's really important that we try to get those claims out, though, correctly the first time. So key points: properly completed pre-registration ensures that the patient access staff will avoid the following issues: return mail, impacting the ability to contact the patients to collect self-pay amounts, insurance denials, missing invalid subscriber information, ineligibility for the service, authorization requirements, out-of-network status, medical necessity failure, and coverage limitation, unnecessarily health plan follow-up, and rebilling. So your pre-registration, your patient access personnel have the ability to really set you in a good place for billing and to kind of reduce liability and risk. But they also, if we fail to collect that information, fail to do what we need to do, then they increase, your risk. They increase your expense. So it's just really important that we monitor this and make sure that those steps are in place. So what is the purpose of insurance verification? Is it 1, to effectively complete the MSP screen process? Is it 2, to complete the guarantor information if the guarantor is not the patient? Is it 3, identify information that does not have to be collected from the patient? Or is it 4, to ensure accuracy of the health plan information? The survey says it is number 4, to ensure the accuracy of the health plan information. Okay. When is Medicare not the secondary payer? Is it number 1, when the patient is working and has insurance through the employer with more than 20 employees? Is it number 2, the patient has has had an accident in their home? Is it number three, the patient is on disability and over 65? Or is it number four, the patient is end stage renal disease, ESRD, and is after the 30-month coordination period? It is patient has an accident in their home. Everything else potentially would make it Medicare secondary. Okay. And we're looking for when it's not Medicare secondary. Okay. So number two. And with that, we're going to, normally we would break for questions, but I am going to turn it over to my colleague and professionals with the Arizona chapter. So thank you. I appreciate getting to speak with you guys, and I hope this was helpful.